So before I introduce you to today's speakers, I just would like to quickly review some housekeeping notes. We appreciate our audience muting themselves during today's presentation, and there'll be an opportunity for questions at the end of the session. We'll be inviting questions both through the chat box or using the raise hand function. If you have questions during the event that you would like the speakers to address, please enter them in the chat box. And lastly, please note that today's session is being recorded, and we will make the recording available on the network's website that will be launching in the coming weeks. So before we begin, I'd also like to acknowledge that this land on which University of Toronto operates for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, and the Mississauga of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Finally, before I introduce our speakers, I'd also like to give a special introduction to Dr. David Neymark. He is a faculty in the Department of Medicine and in nephrology, and has kindly agreed to be our faculty advisor today, and he will lead off the Q&A at the end of our session after the speakers have spoken, and each one will speak for 20 minutes. So I will start with introducing our first speaker, Carolina Gaib. I don't know if I'm pronouncing that right. She is a medical student in third year at the University of Toronto. She graduated from the University of Waterloo with a Bachelor of Mathematics in Applied Mathematics and joined the Hospital for Sick Children, or Sick Kids, as a clinical research project assistant prior to starting her medical training. Carolina's research focuses on the long-term complications of type 1 diabetes in adolescents and young adults. In her role, she is mainly responsible for data analysis as well as the manuscript writing and editing, and she's going to speak to us today on her research. The second speaker is Kaveh Gaynor Sodefi, who is also at the Sick Kids Hospital, and before joining the translation medicine team in the Department of Endocrinology at Sick Kids, he completed a Master's of Science in Kinesiology at McGill University. During his degree, Kaveh was part of the Clinical Exercise and Respiratory Physiology Lab, where his thesis focused on the impact of body composition on standardized measures of exercise capacity in people with chronic obstructive pulmonary disease. And today he is going to talk to us as well about his work regarding nephrotic complication, renal complications in patients with type 1 diabetes. So without further ado, I'm going to pass it on to Carolina. Please go ahead.
Okay, hi everybody. Like the listener said, I'm Carolina, I'm a medical student at U of T, and I've been working at Sick Kids for around 3 years now. And I'll just give you guys an overview of a project that I worked on mainly in the summer and that I'm still working on together with Kaveh right now. So the title of this is Evaluation of Glomerular Filtration Rate Estimation Equations in Adolescents and Young Adults with Type 1 Diabetes. And we already published this project last year, and then there's currently, we're still collecting data from this cohort to follow them up longitudinally. So just to start off with some disclosures, I have none. And as a brief overview of what I'm going to talk about, so I'll give you guys just some background information first on kidney function and kidney function estimation in individuals who have type 1 diabetes. Then I'll talk about the aims of this project. I'll talk about a bit about how the project was conducted, and then I'll explain the results in the end, and then move on to like a brief discussion. So just as a bit of a background, individuals who have type 1 diabetes are at a very high risk for chronic kidney disease, and the incidence of that is even higher in individuals who have pediatric onset diabetes. So to monitor kidney function and follow it up over time, we use something called estimated glomerular filtration rate equations, and those are basically they can either be based on serum creatinine or cystatin C measures that are collected in the lab, and they're usually quite quickly done. There's also a gold standard that's used for kidney function estimation, and Kabe is going to talk about that in more detail later on. But it essentially involves injection of a marker and then monitoring the excretion rate of that marker over quite a long time interval, several hours usually. So that the gold standard is quite a lengthy procedure, and because of the material that you inject, it can be quite costly as well. So in practice, that's usually never done, mostly in the research setting and if you have like very specialized populations. So in terms of eGFR equations, there are two main equations that are usually used in clinical practice. The first one is called the chronic kidney disease in children equation, or CKID for short. This is also known as the Schwartz equation. And that equation is based on a cohort of children who all had chronic kidney disease. And then there's another similar equation, the chronic kidney disease and epidemiology collaboration equation, or CKD-EPI for short. And that's a similar equation, but it's just based on a cohort of adults. So the main caveat that comes with having two different equations for different age groups is that if you transition from pediatric to adult care, like in the reach of like 18 to 20 years, or like even 18 to 25 years, it's not quite clear which equation you should be using, and it's not quite clear which one is the most accurate, because these equations are both based on very distinct cohorts. So to address that limitation, the authors who developed those two original equations last year published updated version that aimed to investigate like a bigger cohort, essentially. So I'll quickly explain the original equations and then the new equations now. So the CKD-EPI equation, that's the one that's mainly used for adults. It's shown on the right here. And it depends mainly on age, serum creatinine, sex, and race. The updated version of this equation essentially retains the same structure. So the equation itself is the same, but it uses what they call age-adjusted creatinine values. And I'll briefly explain this here. So what the authors did is they had a cohort of around 80,000 individuals from 3 different hospitals in Europe, and they collected, and those were aged 2 to 40 years, and they collected their creatinine measures, and then they plotted them and fitted a linear regression model to them. So that now, if you have somebody who has a certain age, you know their age and you know their creatinine, you can use the equations that are here on the right. Those are the ones that are based from the fitting of those creatinine values to the age, to basically age adjust an individual's creatinine value. So what you do to explain this graphically is if you have somebody here, for example, at point A, who is age 10 and has a creatinine value of around like 50 here, you would put that value into the equation on the right. And then what the equation does, it essentially shifts the creatinine value up as if that individual is already 40. And then you use that age-adjusted creatinine value in the original equation to calculate eGFR. So that's the CKD-EPI and the new updated CKD-EPI 40 equation. And the reason why it's called CKD-EPI 40, it's because it's based on a cohort of people who are aged 2 to 40 years. So now this updated equation essentially can be used for anybody who's 2 years or above, because the authors also validated this equation in a different cohort. And now just to talk about the CKID equation briefly. So the original cohort for this equation were children aged 8 to 15 years who all had chronic kidney disease. So that already brings with it two main limitations, namely the fact that the age cohort is quite restricted. So even above 15 years, it's unclear, or like it's the derivation of those equation might not apply to people who are older than that. And then because these people had chronic kidney disease, it's also not certain how applicable this equation is to people who have no compromised kidney function. So to address at least the age limitation, the authors of this paper had another cohort of people. They followed up the same cohort that they used for the original equation over a longer period of time. So in the end, they had a cohort of children who were aged 8 to 25 years. And then they again looked at their creatinine function and their kidney function. And they developed two new equations from this new older cohort. They had this is the original equation that only depended on height and serum creatinine. And then they developed an updated equation here that again looks the same as the original one. It just has two different factors, K, one for males and one for females. So this new one that I called CKID1 in my analysis is sex dependent, and it depends on serum creatinine and height. And then they also went a bit further and developed another equation based on the same cohort that still has a sex dependent factor for K, and then it also incorporates an age term. So this new CKID2 equation depends on sex, age, serum creatinine, and height. So before I move on to our methods, just to summarize the main limitations of the equations that we currently use in clinical practice. So the performance of these equations has not really been properly evaluated in different cohorts. And for our paper, that cohort mainly is children and adolescents who have type 1 diabetes. And then because there's different equations for young adults, sorry, for children and adults, it's unclear which equation is most accurate in the transition age. And it's likely that during the transition period, there's a lot of inaccuracy when using eGFR equations. And then another limitation is that the CKID equation, the original one, has no sex-dependent term. And that matters because serum creatinine, which is mainly used to estimate eGFR, is highly dependent on sex because it depends on muscle mass. And males usually have a lot more muscle mass than females do. So there's already sort of some inaccuracies built into the equation. So then for this study, our aim was to evaluate the performance of all of these 5 equations, so the old ones and the 3 new ones, in adolescents and young adults who have type 1 diabetes. And to do that, we had a cohort of 53 children and young adults from a different trial that was conducted previously. It was a randomized controlled trial, but these people that we had for this study were just from an observational follow-up cohort. And so they had no intervention. And so then we measured GFR using plasma iohexyl clearance. So that's what I talked about before. It's using injecting iohexyl and then measuring that over time to see how much is cleared by the kidney or is filtered by the kidney, and then use that to measure the kidney function. That's the gold standard. And this iohexyl-based clearance was then compared to the estimated glomerular filtration rates. Before I talk about the results, I also just want to explain the performance metrics that we used for the study. So we had bias, which essentially was the difference between estimated and measured GFRs, and we presented that as the mean over all of the differences. And so this means that if an equation had a positive bias, then it overestimated the gold standard, the measured GFR. We also used precision, which is just the standard deviation of the bias. And we had accuracy reported as the percentage of eGFR values that were within 10% or 30%, P10 or P30 of the measured GFR. And we also calculated mean absolute error as our primary performance measure and used the Lin concordance correlation coefficient. So these are our cohort demographics. The mean age was 20 years. We had 5 people who have Black ethnicity. The mean diabetes duration was 13 years, and they all were relatively well controlled in terms of BMI, A1C, and urine ACR. The only difference between male and female participants was that the 2 cohorts, that males had higher serum creatinine than females did, but again, that's just physiologic, that's to be expected. And the mean measured GFR for our cohort was 108 mils per minute. So these are the results. I know it's a lot of data and it's quite a big table, so I'll take it step by step and walk you through it. So the first row here shows the mean estimated GFRs from those 5 equations. And I'll talk about each of those in turn. So just to remind you, the mean measured GFR was 108. So that's our gold standard. That's what we were trying to get as close enough as we could with the estimated GFRs. So the one that went closest to it was the CKID1 equation, which, just to remind you, that's the updated equation that incorporates only a sex term from the original CKID equation, what's also called the Schwartz equation, with a mean eGFR of 107. And then the two others that were next closest to the gold standard were the CKD-EPI40 equation. That's the one that was previously used for adults and now is used for a cohort of people who are up to 40 years old. And the CKID1 equation, that's the original, what's called Schwartz equation. And then the two that were furthest away from it were the original CKD-EPI equation, the adult one, which is to be expected usually, and the CKID2 equation. That's the one that's adjusted for age and sex. If we look at the bias essentially reflects what we see in the mean eGFRs. So the lowest bias was found in the CKID1 equation, followed by the CKD-EPI40 in the CKID equation, and then the highest bias was with the CKD-EPI in the CKID2 equation. If we looked at the precision was actually best with the CKD-EPI equation, so that those values were closest to each other, and the new CKID1 equation. And the mean absolute error, like I said before, that was our primary measure of performance, mainly because it incorporates precision and it's more sensitive than other measures of precision that we had in the study. So that was our primary performance measure. The lowest MAE, again, was found in the CKID1 equation, and then followed by the CKD-EPI40 and the CKID equations. So to compare how these equations performed relative to each other, we used the CKID1 equation as our sort of reference because that one had the lowest MAE. And then we performed just a simple t-test to look for significant differences between the MAEs relative to the CKID1 equation. So looking at the CKD-EPI40 and the CKID2 equation, we saw that the p-value was actually greater than 0.05. So those two equations did not perform any significantly different than the CKID1 equation. But if we look at the other two that we already saw were performing worse on all the other performance measures, the MAE from those two differed significantly relative to the CKID1 equation. And we essentially saw the same thing when looking at P10 and P30, which is just another measure of precision. So another part of the study was also looking at sex differences between the performance of these two equations. So all of these actually performed similar when we looked at performance between male and female participants. The only one that was different was the original CKID1 equation. And just to remind you, that's the only one in the study that didn't have a sex-dependent term. So this result is not really surprising, I think. So we saw that the male bias was negative 4.9 and the female bias was positive 12.4. That's quite different. But the MAE was not different between males and females for any of the equations in the study. So I know I've talked quite a lot. So just to summarize what we essentially saw from all this data. So the best performance was seen with the CKID1 equation, and that's the one that was just adjusted to sex. The CKD-EPI equation, which is the original one that was used in adults, showed the worst bias and accuracy, and that was vastly improved by adjusting for age, by using the age-adjusted creatinine values. But contrary to that, when the CKID1 equation was adjusted to age, we actually saw an increase in bias and a decrease in accuracy, which is a bit surprising. And with the exception of the original CKID1 equation, we saw no differences in performance between male and female participants. So just moving on quickly to what does all of this mean for us. So the CKID in the study, if we just look at the numerical data, it improved the bias that we saw between male and female participants when using the CKID equation. And it also is quite easy to calculate. You don't have to calculate an additional creatinine clearance, and it's quite a simple equation. But there are some limitations with this one still. So the cohort for this one is actually, even this new one was only based on a cohort of people who were younger than 25 years. So again, there's some limitation here because we don't know how this equation is going to perform in a transition age around that time. It also depends on height, which is a limitation for clinical laboratories. So like if you go to like live labs, for example, they don't always have height data available, or like they have to infer it from somewhere else. So that's not as accurate as it could be. So that poses another limitation. And it's still only based on a cohort of individuals who all have chronic kidney disease. So again, it's unclear how this will be generalizable to people who have preserved kidney function. The other equation that performed quite well in our study was the CKD-EPI40 equation. And as we saw, there was no significant difference from this one in terms of MAE to the CKID1 equation. This one actually is based on a much wider age range for the cohort, from 2 to 40 years. So it can now be used in anybody who's older than 2, essentially, without any weird like anomalies around the transition age. It's a continuous equation, which makes it very easy to use. The only limitation with this one is that it requires the computation of those adjusted creatinine values, which, if it comes down to it, that's just one equation, that like one extra step, but it is an extra step, so it adds a little bit more work. The study that we conducted here also had some limitations. So our patient cohort was quite small, only 50 people. And as we saw from the demographic information, our participants were fairly homogeneous in terms of age and kidney function, and diabetes duration and A1C. So again, there is some question as to the generalizable. It's unclear how generalizable our findings are to different cohorts. And this analysis is only based on cross-sectional data, and Kaveh is going to talk about this more, because we are following these people up over time, because we want to see how well these equations perform as the individuals grow up and, you know, age from 20 to 23 to 25 years and older. And then lastly, the GFR that we use is based on what's called a one-compartment model. The intricacies of this aren't too important, but usually you need several more sets of IRHEXO values to calculate a full measured GFR. But that adds a lot of extra work for the clinical staff, for the research staff, and it gets quite costly as well. So just to conclude of what I've talked about, there is potential application for these new equations, mainly the CKID1 and the CKD-EPI40 equation for young adults and adolescents with type 1 diabetes and preserved kidney function. We need some longitudinal follow-up data to say how these equations perform over time. And there will always be some limitations to using estimated GFR. And that sums up my talk. So thank you so much for listening. And I think Kaveh is going to take over now.
Thank you very much, Carolina, for a wonderfully and well-explained talk. Yes, Kaveh, if you can just take over now. And just so people know, Kaveh, unfortunately, he doesn't have camera ability, so we will be listening to his voice. Go ahead, Kaveh.
Okay, thank you very much. Yeah, sorry about the camera issue. Hopefully my voice will be sufficient. Yeah, so thank you guys for all hopping on and staying on and listening to our presentations. So my study that we're going to be talking about, that Carolina has also been a part of, is kind of a continuation or the other side of the coin with regards to assessing kidney function using measured GFRs. So instead of the estimated equations that Carolina spoke on, I'm going to be kind of talking about the measured aspect of kidney function. Let's see, perfect, and no disclosures related to this program. So I guess just very briefly, talking about kidney function and type 1 diabetes. As many of you are probably aware, type 1 diabetes is an autoimmune disease that kind of affects the ability of the body to produce insulin. And so insulin is an important hormone to control blood sugar homeostasis. And the inability to kind of produce insulin and control blood sugars can lead to certain complications. And so this is just kind of giving you a quick overview of some of the complications that can arise in diabetes. So you have cardiovascular disease or damage. You can have cerebrovascular, so damage to the brain, retinopathy, so damage to blood vessels in the eyes and the ability for the eyes to function properly, periodontal, peripheral vascular, neuropathy, so nerve damage, which can lead to issues with foot and infections, and then probably classically known kidney disease or kidney damage, also called diabetic nephropathy. And so really, in its most basic definition, diabetic nephropathy is just damage to the vasculature of the kidneys. And this can impair the kidney's ability to do its job, which is filter blood. And so over time, with repeated bouts of damage to the blood vessels, the kidney's ability to filter blood can be severely impaired. And this can progress from diabetic nephropathy to full-out kidney disease. And this isn't a minor complication that only happens in a small set of people with diabetes. It's approximated that 1 in 3 people with type 1 diabetes will progress to having kidney failure. So this is not a small subset of people. It's a pretty important and pervasive issue. So much so that diabetes itself is actually the #1 leading cause of kidney disease. So again, it's not only a major burden to the individual, but also to the healthcare system in general. And as Carolina was talking about, adolescence and sort of the transition from childhood to adulthood is a really important time for the onset and the development and the progression of a lot of these diabetes-related complications. And so our cohort, who are young adults who joined when they were actually still going through puberty as adolescents, is a really critical time to start monitoring these patients for progression of a variety of these diabetes-related complications. And so this is an important one because it really does impact the trajectory of people living with type 1 diabetes. It can impact quality of life and general outlook in terms of well-being, because the earlier the onset of these issues and the earlier the development, it can result in more rapid progression and earlier disease-related issues than someone who has it maybe develops it later on in life. Unfortunately, though, our ability to predict those who are most at risk is still limited, right? And so we really want to be able to improve our ability to identify and prevent any further progression or rapid progression with these diabetes-related complications, and really help slow that progression down. But we have to improve our tools to do that first. And so how do we assess kidney function? Again, 2 ways kind of already talked about by Carolina. There's the eGFR, which is the estimated GFR, and then there's mGFR, which is measured GFR. And so yeah, just very quickly, eGFR uses a calculation, and it usually will incorporate a couple different variables, depending on the specific equation. So height, age, sex, and then creatinine, which is a waste product that comes from the muscle. There's also something called cystatin C that is a protein, which slows down the breakdown of other proteins, I believe, but that can also be used as your substance that you include in the equation to calculate eGFR. On the flip side, there is mGFR. So this is actually more directly measuring the kidney function filtration rate. And this can be done through assessments of plasma that you pull from the body, so blood measurements or accumulation in urine. So you can actually have participants void every 30 minutes to an hour and measure clearance rates that are actually in the urine. And this is done with an injected substance. So a lot of the times nowadays we use iohexol, and that's what we used. So you inject iohexol through an IV, and you measure the clearance rate in the blood to determine the filtration rate of the kidneys. Each have their own, advantages and disadvantages, and they're applicable in different settings. So just to kind of quickly give you a little table of some of the pros and cons for eGFRs and mGFRs. So right off the bat, eGFRs are by far less invasive and more comfortable, so less uncomfortable. It only requires 1 blood draw to measure creatinine, and then everything else can be measured externally, so height and weight, and you plug in an equation and you're done in 5 minutes. mGFRs, it requires IV lines. You have to constantly monitor blood. You have to do multiple blood draws, and it can take upwards of 8 hours. So it's a much more invasive and much more lengthy and uncomfortable procedure. However, on the flip side, mGFR is not creatinine, it's creatinine independent. So it doesn't matter the concentrations of serum creatinine, and that can actually be beneficial, which I'll discuss quickly in a minute. Again, quick assessment, so kind of going on the side of uncomfortable. It can be done in 10 minutes versus an 8-hour procedure. MGFRs being the gold standard and being a more accurate measurement is more applicable in certain chronic diseases. And so that kind of applies to type 1 diabetes as well, where it has a bit more validity in using it in certain chronic diseases. Cost and personnel, again, you don't need a lot of equipment, a lot of time, and a nurse and a physician constantly checking and monitoring the patient. So much cheaper and much more easier in terms of personnel usage. But the gold standard, again, is the MGFR. So that's really the best way of getting the most accurate measurement, if that's what you deem the most important. And so here, this little table on the right here is just kind of showing you an example of why being serum creatinine independent can be beneficial. This is actually from a patient we had come in who did an MGFR with us this past year. And so as part of the pre-procedure assessments, we measure creatinine levels in each of our participants before we actually inject the iohexol and proceed with the MGFR procedure. And so what you can see here is this participant had an initial value of 105 for their serum creatinine, which was high, and the attending physician wanted to see if we could bring that down a bit before proceeding with the MGFR procedure. And so what we did is we had them drink some water and gave them a bit of time before we took another measurement, at which point their serum creatinine dropped to 90. So rehydrating them helped sort of bring down that value and flush out perhaps some of the creatinine that was currently in their system. And this resulted in about a 10 millimeter per minute difference in eGFR value. So again, not huge, not massive, but it can be still significant. And this is bringing them down to almost a level of kidney disease values in terms of millimeters per minute. So this is just to kind of say that creatinine can vary throughout the day, depending on how hydrated you are, if you're taking protein supplements or creatinine supplements. And so the equations may be influenced by external factors that aren't specifically related to kidney function. So just to kind of show you some of the caveats and why we may want to proceed with MGFRs when wanting a very accurate measurement of their kidney function. So again, I just talked about this, but yeah, considering the variability of serum creatinine dependent equations and the reduced accuracy in some chronic conditions like kidney disease, we may want to sometimes take eGFRs with a grain, not with a grain of salt, but with a caveat saying, okay, maybe we should assess with MGFR depending on what the eGFR brings back. But on the other side, MGFRs are still very costly. They require specialized personnel, a lot of time. They required a bed in a hospital. So it's not the most convenient thing, and it's currently really mostly done in research settings rather than clinical settings. But if we can, try to improve and make the MGFR a bit more of an efficient process, maybe it'll be easier to increase the utilization of MGFRs in a clinical setting when we want to gather more information in terms of the accuracy of kidney function assessments. So this is kind of leading into the objective of our study is we wanted to compare sort of the standard MGFR, so what's currently being done, with some alternative exploratory MGFR calculations that use shorter and fewer blood draws. And really the aim of that is to help make the assessment a little bit more quicker by cutting down the time it's needed. And that will also help affect the cost. Not so much the personnel, but if we can shorten the test by 30 minutes, 60 minutes, even 90 minutes, that will help free up, nursing hours, physician hours, the burden of the participant having to be there for that time. So it can really help with the cost and the utilization of MGFRs. And again, yeah, just to really hopefully improve the feasibility and the practicality of the test without significant attenuations in precision and accuracy, right? That's really important. We don't want to compromise the accuracy of an MGFR to help make it more cost effective and quick. And so what we did is we say the same with Carolina. We have a current observational 5-year observational study with many participants who are currently diagnosed with type 1 diabetes, and we've been following them for the past 5 years. Not everyone in that cohort gets an eGFR procedure. So here we have 46 participants who have done an eGFR procedure, who we have data for and who we've used for this initial study. I just want to mention that this is sort of the beginning of this project, so we're not really haven't advanced too far, but we're still kind of playing around and exploring this eGFR study. So pre-eGFR procedure, we had them come in fasted at 8 a.m. in the morning, and we tried to have their blood sugars come in at around 10 millimoles per liter. Once they were stabilized at around 10 for about 2 hours, we injected iohexol, so the traceable substance that we're going to be measuring the clearance rate. We maintained their blood sugars between 9 and 11 millimoles per liter. So they had an IV with both insulin and D5, so just basically sugar. And we controlled it and either increase or decrease both insulin and D5 to accommodate this 9 to 11 target. And then we took blood draws to measure the clearance of iohexol in the blood over the duration of the eGFR. So just to quickly kind of show you the blood draws, might be a bit confusing, so I'll just work through it. So here's the reference. So this is kind of the standard procedure for eGFRs currently done in the clinic. So you have an injection at time 0, and then you have every 30 minutes, starting at 60 minutes post-injection, you start taking blood draws. So 90 minutes, 60 minutes, 90 minutes, all the way to 240 minutes. And that's sort of the reference where you take only the values at 120 to 240, and you use those to calculate glomerular filtration rate using those time points. But then what we wanted to do is we wanted to explore a variety of different alternatives to see if we can get accurate measurements while also either decreasing the number of blood draws, the time of the test, or both. So just an example here, if you look at this top one, the first 4 time points, what we've done is we've moved it up and we've started using the blood draws from time 60, 90, 120, and 150, and compared to the reference, which is only starting at 120 and ending at 240. So decreasing the number of blood draws by 1, so 4 versus 5, but then significantly decreasing the actual time of the procedure by a whole 90 minutes, which can be quite significant in terms of the time commitment and the cost of the procedure. So after collecting and analyzing those different ones, we had a couple different definitions, which I'll just show you here. So GFR, which is the filtration rate, is presented as mean standard deviation. And very similar to Carolina's, we had bias, which was just the median difference between the reference and whatever sampling combination we were looking at. Precision, again, is the interquartile range, so how close they were. And then MAE was our main outcome of interest. So it's the mean absolute difference, or mean absolute error between the reference and the sampling combination. And we use paired t-tests to compare the lowest MAE of the exploratory equation with the other MAEs. And so we'll just look at the results quickly. So table 1, again, just like Carolina, because these are from the same sort of cohort, very homogeneous. So, you know, young adults, roughly 22 years of age, about 50% female, only about 11% were Black. BMI was in the normal to slightly overweight range at 27.6. And then their diabetes duration was about 15 years on average. And here what it is just the actual absolute or average value for filtration rates using all the different values. And I think what you can appreciate right away is just how close the eGFR procedures were together. If you look down here, we also included eGFRs. I don't go too much into eGFRs in this presentation, but quite a bit higher compared to the eGFRs. And this is, again, just to kind of show you, you know, if you look here, last 5 time point reference, that's here. And then if you have first 4 time points, that's this one here. So cutting down that procedure. So this table is now looking at the actual performance of the different eGFR sampling combinations and compared it to the reference. So your most left column is the reference. So there's no bias or precision values for that because that is what is being used as the reference value. And then here are the different sampling procedures. So we just sort of isolated to the first and middle 5 and first and middle 4 and then all 7. And you can see here with the bias, the first 4 actually scored the best or did the best in terms of bias, but with our main outcome, MAE, it was the middle 4 and the middle 5 that had the 2 lowest MAE values. With that being said, if you do look at the p-values with the middle 5 being the reference because it was the lowest MAE value, the first 4, the first 5, and the middle 4 all were not statistically significantly different. So they're actually they all performed quite similarly in terms of MAE values. And again, P5 and Lin's concordance correlation also scored quite well. So all of these metrics or all these variations in the MGFR procedure actually performed quite well when compared to the reference MGFR. And so to kind of just quickly discuss, again, this is still early. We have another year of MGFRs being done right now, and they'll be completed hopefully by the end of November. And so we look to include that round of MGFRs in this study to really validate our findings and to compare year over year change in MGFR because they will be the same participants. But our goal was to really investigate the performance of MGFRs using fewer and earlier blood draws compared to the standard or the conventional 5-sample blood draw. And again, from the table you just saw, our MGFR calculations actually performed quite well, and they were within clinically acceptable variations when compared to the reference MGFR. And just to, in terms of MAE, the middle 5 calculation had the lowest, and they also had the best in terms of those falling within a 5% difference of the reference MGFR. Middle 4 also did well, and so here's just kind of showing you the potential improvements in just those two. And again, if you took the first 4 time point MGFR calculation, that's actually improving the procedure by a whole 90 minutes. So there is some potential benefits and use in maybe cutting down this test and making a bit more and utilizing a bit more in perhaps a clinical setting. But again, this is just very preliminary stuff and not conclusive by any means. And to discuss some of the limitations, again, this was a cross-sectional study as of right now, so we're not able to assess the ability to detect change over time. We will have another year of MGFR procedures by the end of 2022, so maybe we can start looking at changes over time, but as of right now, we don't have that, and so we can't assess the ability to, the longitudinal aspect of MGFR change. And as Carolina mentioned, it's a pretty homogeneous group in terms of age, sex, and race. And the sample size, only 46, limits its ability to extrapolate to other populations. And finally, these patients had relatively preserved kidney function. So they were all within above 100 milliliters per minute. And so we don't know how applicable these equations may be in someone who has deteriorated kidney function below 60 milliliters per minute. And so that's something we would also have to sort of look at and assess. And yeah, that was it. Thank you for everyone for listening.
Kaveh, thank you so much for a very wonderful talk. And once again, thank you to Carolina as well. I'll now open it up for the question period, and we'll start with Dr. Neymark. Go ahead, Dr. Neymark, if you have questions for one or both of them. Sure.
I'd just like to commend both on really clear presentations and interesting work. So I'll direct a couple of questions to Carolina. This also applies to Kaveh, and maybe I'll give him a chance to answer this too. So just from a methodological technical perspective, I'm trying to understand why the mean absolute error wouldn't be identical to the bias. Can you straighten me out on that, Carolina?
Yeah, so just from like a calculation point, like the mean absolute error it's like the only difference in terms of calculating it is that you take the absolute value. So what you do for the bias is you calculate the differences between the estimated and the measured GFR, or in Kaveh's case, your reference equation, and then the one that you're trying to evaluate. And then you, for each participant, you do that, and then you take the mean of all of those differences. What you do differently for the MAE is you take the absolute value of that difference before you average them all out. So it gives you more of an idea how far you're sort of away from your reference on like an absolute scale rather than like the directional point.
Okay. So my understanding is the bias is the difference of the means, and the absolute error is the mean of the differences. But it's all linear, so shouldn't they be the same?
Yeah, I think because you take away the the sign when you calculate it, now you've got me. So we worked on this and maybe Kavi can speak to this too. We're working on this in collaboration with somebody at Kingston, and she usually works on like something like this, like kidney function estimation. And she recommended using this because she said it's a more it incorporates precision, and it's sort of like the P10 and P30, but it's more sensitive to what you do with those values.
Yeah.
Okay. Kavi, do you want to have
yeah, I just to add to that, I think why it wouldn't be, I guess, identical or the same in terms of bias versus mean absolute error. Just as, I guess this can be as a theoretical idea. Say you have patient 1 who has a difference of -5 milliliters per minute, and patient 2 has a difference of +5 milliliters a minute. When you average the bias, that would be 0. But when you take the mean absolute error, they would both turn to 5, and the average would be 5, if that makes any sense. So by absoluting the values, it actually changes it compared to when you just take the actual bias, which could be negative or positive.
Okay, that makes sense. All right. So question to Carolina, the CKD-EPI equation that you presented, it was the CKD-EPI 2009 equation, if I'm not mistaken.
Yes.
And of course, subsequently, there have been further refinements on that equation to incorporate cystatin C, and the latest, the CKD-EPI 2021 equation, eliminates race as an input to the equation. So, looking forward to seeing more adoption of cystatin C as a marker, and maybe of this new equation that eliminates race as an input. I'm just wondering whether you considered cystatin C as a marker, and whether you considered these other equations in your study, because perhaps they would perform better than the original 2001 equation.
Yeah, so we did talk about cystatin C. I think it was at the time that we conducted the study, we actually didn't have the cystatin C measures available, so we couldn't evaluate, but I think our entire group is aware that a lot of the eGFR equations nowadays use cystatin C, and even the ones that I had in the study, like the new Schwartz equation, for example, had like a version that incorporated creatinine and then another one that incorporated cystatin C. It just, we didn't have the measure available when we were conducting the study. And then in terms of race, I think as you saw, I think from the cohort that we had for the study, they were quite homogeneous. Like we only had 5 Black individuals, so we didn't have the numbers really to investigate any of those changes to the equation.
Thank you very much. Okay. I think I'll just direct one more question to Kaveh, and then turn it over to the group. As you're probably aware, one of the not so nice things about creatinine as a filtration marker is that it's horrendous variability. So it's biologically variable day to day. People's values change because of metabolism, hydration, etc. And there's tremendous assay imprecision. So we see this quite commonly in clinic, that people's creatinine values over time look like a saw blade, just up, down, up, down, up, down. So how much less variable are measured GFRs? Do you have an estimate of how variable the actual measured GFRs are?
Oh, that's a great question. I can't say off the top of my head that I know how much less variable they are compared to an eGFR. And I know that even, for example, in assays with iohexol, dependent on the machine, the data that's done, iohexol variations can vary in a lab. But as you mentioned, knowing how variable creatinine is and how important that is in the equations of eGFRs, I can only speak to saying that MGFRs are probably, hopefully, less variable, considering that they don't incorporate creatinine in any aspect of their calculations. But to say how much less variable an MGFR is compared to an eGFR, I'm not exactly sure.
Okay. Those are my questions. Again, just thank you very much for allowing me to participate.
Oh, thank you, Dr. Neymark, for great questions, and hopefully prompted some reflection by the speakers. So before I open it up to the group in general, I'll start by reading one of the questions that came in the chat. So this is from Dr. Calvin Kay. Can you elaborate on the use of such equations across different ethnic populations? Great question. I don't know, one of you wants to take it. Carolina, do you want to try?
Yeah. I guess, maybe I'll take it because it's more relevant for eGFR equations, I think. So the ones that I presented on today, they were, again, based on not just from my study, I mean, but for the cohort that developed, for the group that developed these equations. They are based on a quite homogeneous cohort, and they did incorporate a race term previously because it was thought that changes how creatinine is filtered by the kidneys and how it's excreted. But like Dr. Neymark said, I think recently there's been a big shift in like the literature and the way creatinine is estimated through eGFRs, or the way kidney function is estimated through eGFRs. So I think in the future, I don't even know how relevant like equations that incorporate a race term are going to be, because there's a shift towards moving away from those equations and having like a universal equation across all races. So something like what I talked about today will be relevant in terms of creating equations that are applicable across wide ranges of ages, but I'm not sure that these per se will be still be relevant in the future, if that makes sense.
Mm-hmm. Mm-hmm. Thank you, Carolina. Kaveh, do you have anything to add? Maybe 30 seconds or less?
Yeah, quickly, I am not so much with the MGFRs. There is not really an incorporation of ethnicity or race in MGFRs in terms of how you calculate it.
Great, thank you. Well, we're just about out of time. So before we move on to closing remarks, does anyone else have any questions from the audience? You can just either raise your hand or take your mute off. We're a small group here now. No? Okay, terrific. Once again, I would like to ask you to join me in a big thank you to Carolina and to Kaveh for really well presented, interesting presentations, wonderful projects, and I think this really clinically relevant and important for all of us. And I'm hoping to see more of your work as you expand beyond people with type 1 diabetes to potentially people with type 2 diabetes, older populations, people without diabetes. I think this is really important work. So thank you very much for your presentation. I just wanted to let everybody know that these joint rounds are quarterly, the BBDC Novo Nordisk Network rounds. And so I believe our next one we will be announcing in the new year. But in the meantime, we will be having another seminar next month for our Novo Nordisk Network for Healthy Populations. And this one will be a very exciting one. It will be the inaugural Novo Nordisk Network Catalyst Grant Pitch Competition. It is on November 21st, and it will be from 12 p.m. to 2 p.m. So an extra hour, but it promises to to be really exciting. It's an opportunity for everyone from the University of Toronto diabetes community, as well as the Peel community and beyond, to learn about projects that were submitted during the first phase of the Network's Catalyst Grant competition. So we welcome you to join us as project teams pitch their Catalyst Grant proposals to a panel of esteemed judges who will determine at the event which projects will proceed to the next round. So, and it's also meant to connect applicants to potential stakeholders wishing to partner with them for co-development, and as well academics who want to look for collaborations. So we hope to see you all there. I believe the Lydia gave you the registration link in the chat, as well as please complete today's session evaluation here. And without further ado, I would like to once again thank everybody, and this closes the session. Thank you so much.